content today will be, I will just briefly mention why we need to know the mechanism of action, the classification as in physical versus biological interaction, then biological interaction, the classification of mechanism of action mostly divided into receptor and non-receptor linked. We'll go into the basics of receptor mechanism. Can please mute the other person? So then we go into concept of agonist versus antagonist, and our core recipe, which is the G protein coupled receptor, and very briefly on the non-receptor mechanism. And then finally, the homework would be the common drugs and mechanism of action. I'll come to that later. So this is the core recipe. We're going to talk about this famous receptor, G protein coupled receptor, which is the core receptor which involved in almost 70 to 80% of the drugs that we use, especially anesthetics. So we have to know this in and out. So this topic, my majority of my slides will be talk about this, but we also touch on other types of mechanism of action. So what is mechanism of action? It's what's happening at the cellular level. When we administer a drug, what does the pharmacodynamics all about? The drug's effect on the body. What does the drugs do to the body? So this is talking about the cellular level. What we see is when we administer drug, we only see the effect, whether it's a desirable or adverse effect. But what is the cellular level response that bring about this desirable or adverse effect? That is mechanism of action. And then understanding of this mechanism of action help us to modify it. So as in agonist to bring about the desirable effect that what we want, or adverse, and then antagonist. So to bring about the effect that wanted. So modification of this mechanism of action is the evolution of the drugs. So do not memorize the individual drug mechanism of action. You're going to get overwhelmed. Understand the concept and the broad group they belong to. Each group acts via certain type of mediator. The broad concept then can be applied to individual drug. You understand, okay, this group belongs to this receptor, then you don't have to, okay, they work via this mediator, these are the second messenger, that's it. You don't have to memorize it for each of it, okay? All the classification of group, they belong to certain mediators or certain receptors. So we go to the types and grouping. This is the best classification that I think is for mechanism of action that I found and then I used during my primary as well. So you divide it, mechanism of action, into physical versus biological interaction. Physical is just basically how the drug physicochemical properties directly interact at a physical surface. As an example, when we give antacids, how does it go to the stomach lining and how does it neutralize it immediately without undergoing any chemical reaction? And bisphosphonates and then mannitol, that is physical reaction, which is kind of straightforward. Not much of cellular response going on there, which is cascade of reactions also. So we're not going to delve into it much. What we're interested is the biological interaction. So the biological interaction is divided into receptor based and non-receptor based. Most of it are receptor based and few others are non-receptor based. So in which we have to find out the receptor based divided into four main types. The number one would be your coupled to G protein, which is G protein coupled receptors, where most of our drugs uses. Okay, G protein coupled receptors are your acetylcholine receptor, your inotropes, your opioids, all these are G protein coupled receptors. Okay, then there are receptors who's linked to ion channels as well. Okay, I need to find out who's not yet mute. Yeah. Can somebody mute who's the person who's not muted? Okay. So next would be the receptors which are linked to ion channel, where we call it as a ligand gated ion channel, because receptors, they must have a ligand that binds to them. So that is ligand gated ion channels. As in, again, your acetylcholine. Acetylcholine can be muscarinic or nicotinic. So the muscarinic are G protein coupled receptors, whereas your nicotinic are ligand-gated ion channel, which is your muscle relaxants and everything. Your acetylcholine at the muscular contractions, it's nicotinic, it's ligand-gated. Okay. Where your acetylcholine directly go bind to the receptor and bring about your action. Whereas at the muscarinic level, acetylcholine muscarinic receptors are coupled to G protein. We'll talk about it soon. Then another type of receptors are linked to enzyme linked receptors. It means there is ligand binding to the receptors, bring about conformational changes of these enzyme that is linked to the receptor, bring about the effect. Finally, we have nuclear receptors, which is linked to gene transcription. Again, there are receptors, but they will be directly affecting your gene transcription, as in your DNA and RNA synthesis. So these three, couple G protein, linked to ion channel and linked to enzyme, these are all cell surface receptors on the outside of the cell. They are attached to or integral, but this is intracellular. This can be in cytoplasm or it could be in nuclear. It's either cytoplasmic receptors or nuclear receptors, broadly classified as intracellular receptors. These three are cell surface. This is nuclear receptors. The most common example would be your steroids and your thyroid hormones. Okay, thyroid will be cytoplasmic, steroid will be your nuclear. Okay, for your enzyme linked receptor will be most common will be tyrosine kinase. Okay, and next will be your next we go to non. So in this, most important is the G protein coupled receptors. Others are important as well, but the most common one that we're going to talk about is the G protein. Next, we talk about non-receptors biological interaction. There's no receptors. Okay, these are enzymes where they directly causing having conformational changes upon binding of a drug. They are not linked to a receptor. They are not attached to a receptors. Okay, so which is your ACA, angiotensin converting enzyme, your NSAID where cyclooxygenase, and your DNA altering enzymes. So all these, even though here they classify enzyme, all of them are somehow linked to the enzymes as well. Even DNA anti-cancer drugs will infect your enzymes involved in your DNA production and microtubules as well. And there are some are carrier transporters affecting drugs. Okay, they affect the carrier transporters, especially like omeprazole, where proton pump inhibitors. And finally, we have ion channels, direct ion channels. Okay, drug interaction with direct ion channel. These are voltage sensitive. Whereas the receptor based are ligand gated, means there must be a ligand must bind. Okay, and the ligand binding to receptor, and these ion channel attached to the receptor thus undergo cascade of reaction. Whereas here the non-receptor, the ligand, which is the drug, directly bind to these ion channels, causing a voltage differences, voltage changes. Example would be your La and your calcium antagonist. So we'll go into each of these class in detail. So biological or chemical interaction, first the receptors. So what are the receptor? What is a receptor? It can come out as a short note or SAQ for 2 or 3 marks. Write a short note on receptor. So if you're able to give me this much information about a receptor, you can get full mark, which is it's gonna be not gonna be a long SAQ, it's gonna be a short SAQ, which is 2 or 3 marks. So receptor basically it's a protein. Okay, and it's often attached to or spans the membrane, which is your cell surface receptor. You can write it, classify into cell surface or intracellular receptor, where cell surface receptor often attached to or spans the membrane, whereas intracellular receptor are in cytosol or nucleus. You want, you can give example directly. Here you can put directly G protein coupled receptor. Here you can put steroid receptor, or for tysosol you can put thyroid hormone. Nucleus you can be steroid receptor. And then all of them must have a ligand binding. There must be a ligand that binds to the receptor for this drug response to occur. So the ligand that binds can be agonist or antagonist. Okay, we come to a concept of agonist or antagonist later. So the ligand that binds can be an agonist or antagonist. Upon binding of these receptor, there will be a cascade of reaction which may or may not involve a second messenger, thus producing response or no response in case of antagonist. Depends. The response can be a good response or no response or bad response. Okay, so this is the limited information which is enough to actually explain what is a receptor. As I mentioned, receptors can be classified few types. One type is when we mention about the location of it. Cell surface receptor would be your enzyme linked G protein coupled receptor or ligand gated ion channel, where your intracellular receptor would be your cytoplasmic or nuclear receptor. Okay. So when we talk about intracellular receptor, the drug must penetrate the cell surface membrane, go into the cytoplasm. If the receptor is in the cytoplasm, it will interact with the cytoplasmic receptor. If it's in the nucleus, it has to penetrate the nucleus and it will alter the gene transcription, thus protein synthesis and cellular effects. Okay. If it's a ligand-gated ion channel, the binding of the receptor, this is your receptor, the yellow color, the R is your receptor. In case of intracellular, you can see it's inside the cell. This is the cytoplasm. This is talking about the nuclear receptors. That's why they put it inside the nucleus. The intracellular receptor can be in cytosol as well. If we talk about ligand-gated ion channel, there is a receptor which is linked to ion channel. It is combined. It's a package. So when there is a ligand bind to this receptor, this ion channel will undergo conformational change, either opening or closing. Okay, that will lead into ion passage through this channel, causing hyperpolarization or depolarization, bring about cellular effects. Then we have G protein coupled receptor, where there is a G protein. Okay, it's we talk about the structure of the G protein. Okay, it is this G protein is attached to the receptor. So upon binding of this ligand to this receptor, this G protein will undergo a ion differences and or it undergoes a second messenger system. It depends. Okay, G protein can be either works through a effector or it works through an ion channel. Both also can. So there will be a second messenger system which involve protein phosphorylation and etc., causing cellular effects. Okay. Next would be your enzyme linked receptor, where the receptor is directly related to an enzyme. So a ligand bind to the receptor, that binding of the ligand to the receptor causes conformational change in the enzyme. Protein phosphorylation occur, then thus the cascade of reaction occurs until bring about the cellular effects. So this is classifying receptors based on the location. There is another classification where they do talk about, which may be come out in MCQ as well, which is they talk about inotropic versus metabotropic receptor. Basically, inotropic receptors are ion channels, the receptors that's linked to ion channels. Metabotropic receptors are metabolism. There must be some kind of second messenger system involved. Okay, cascade of reaction. So that is example is G protein coupled receptors. Inotropic receptors mean binding of a ligand to a receptor directly involved to ion channels. Okay, whereas metabotropic receptor binding of a ligand will initiate a cascade of reaction involving a second messenger system. So what is the most important difference is in inotropic receptor, the effect will be faster. Ligand bind immediately goes through the changes in ion channels, then the effect is faster, whereas in metabotropic receptor, the effect might be a bit slow. But in inotropic receptor, since the action is fast, it might be a short-lived action. Whereas in metabotropic receptor, because of the second messenger system, your signals are being amplified. So it's an amplification process, thus the effect may be prolonged. So that's the difference between inotropic and metabotropic receptor. This is another way of classifying receptors as well. Okay. Then we go to basic mechanism of action, which is what is as commonly occurs in 3 steps is a ligand binding to the receptor, like a lock and key. It binds first. It can be agonist or antagonist. That is a reception. Next, transduction. Transduction is binding of this ligand to a receptor causes some conformational changes or some protein degradation or some cascade reaction goes on, which involve a second messenger. Okay, these conformational changes or cascade of reaction produces a second messenger. This second messenger system, if there is a second messenger or these conformational changes, will bring about cellular response either directly or either by cell signal amplification. Okay, so reception, transduction, and cell response. These are the 3 stages involved in any receptor-based mechanism of action. Next, we come to the interaction between receptor and ligand, the broad concept of it, which is when we talk about receptor and ligand, we have to know about affinity. So affinity is how avidly a drug binds to a receptor or ligand. Okay, a drug is a ligand. Ligand means any substrate to a receptor. So it can be a drugs, it can be a chemical neurotransmitter, whatever. So here we use as a drug. So how avidly, how strongly a ligand can bind to a receptor, that describes the affinity. Then we go to a concept of intrinsic activity or efficacy is magnitude of the effect of the drug once bound or the ligand once bound. Okay, that's, let's say a ligand A bind to a receptor A. Affinity would be how strongly they bind. That is the affinity. Once they bound, how much of effect, how much of intrinsic activity they can bring about. The intrinsic activity can be a positive effect or negative effect. It can be a desirable effect or it's an undesirable effect. Doesn't matter. It based on that receptor punya intrinsic activity. What type of receptor is it? Is it a good effect receptor or bad effect receptor? Doesn't matter. But binding of this ligand to the receptor, the magnitude of the effect, is it a maximal intrinsic activity or partial intrinsic activity or null, no intrinsic activity? That is IA. So we come to a concept of agonist versus antagonist. A full agonist will have a very good affinity to a receptor. They will strongly bind to a receptor and they will have a good intrinsic activity, or it almost produce near maximal intrinsic activity. When they bind vividly to the receptor, then they will elicit a good intrinsic activity, good response. Whereas partial agonists will have a good affinity to the receptor, but their intrinsic activity will be submaximal, will not able to produce the 100% intrinsic activity. Antagonists also have good affinity, but they have no intrinsic activity. So all of them have good affinity, okay? They all are ligand that can bind to a receptor very good, but it all differs in the terms of intrinsic activity they elicit. So you have to understand this concept. So agonist versus antagonist. Agonist, drugs that occupy receptors and activate them. Activate them as in produces intrinsic activity. Antagonist, drugs that occupy receptors but do not activate them. It means they do not produce intrinsic activity. Antagonist block receptor activation by agonist. Once an antagonist bind, it prevents an agonist to bind. It becomes a competitive antagonism. Okay, it's whether the antagonist can be competitive or non-competitive. That's another topic lah. We're not going into it. So again, agonist bind full activation, high affinity, maximal intrinsic activity. Antagonist also bind very nicely, but no activation. So high affinity, no intrinsic activity. When there is a competition between agonist and antagonist, there will be a less activation or less intrinsic activity. Or if this is a partial agonist, also same. Partial agonist will have a good affinity, but less activation, submaximal intrinsic activity. So this is your receptor side, natural substance. Let's say this is a natural chemical neurotransmitter in your body. Okay. We'll take a simple example, acetylcholine. Okay. You have your nicotinic receptor. You have your acetylcholine as a natural substance. Will come and bind to it. Will cause a normal cellular activity, which is a muscle relaxant. Okay. Muscle contraction. Then you have agonist drug, which is succinylcholine. Succinylcholine is a muscle relaxant, but it's an agonist. It's not an antagonist. It's an agonist at the nicotinic receptor. It's structurally mimicking acetylcholine, but the way it produces muscle relaxation is in a prolonged depolarization. Okay, so succinylcholine binds to it. It causes enhanced cellular activity. That's why you see this muscle fasciculation. It causes prolonged depolarization and a brief sustained muscle contraction. Then after that, patient go into a relaxation. Whereas antagonist, as in you give atracurarium, which antagonist binds to the receptor as well, good affinity, and it blocks the cellular activity. No muscle contraction, and it prevents any natural substance, which is acetylcholine, binding there also. This is the brief explanation of talking about agonist versus antagonist. When we talk about agonist versus antagonist, these graphs you must know. First, we talk about the intrinsic activity graph. You have a basal activity. Okay, you have an agonist. The agonist will give almost 100% of intrinsic activity. This is receptor response. Okay, this is your intrinsic activity. You have a partial agonist. It gives us submaximal. Antagonist, it does not produce any effect. Inverse agonist will be low. This
graph you all must know with example. The easiest example you can talk about this is using opioid. Okay, opioid will be a good example for all these things. You must know your by heart all these things with trying to explain with an example which is easily used an opioid. Your full agonist will be a morphine, partial agonist will be a buprenorphine, antagonist could be your naloxone, and you have your inverse agonist as well. Okay. Then we have, when you talk about this graph, another drug that you must mention about your EC50. Okay, this is drug response relationship. Okay, receptor drug response relationship. So when you give your full agonist, your EC50 is lower because you can reach your maximal activity at a lower concentration. When you give partial agonist or any agonist that has lesser intrinsic activity, your EC50 is further increased. So that is the idea of talking about EC50 relating to your intrinsic activity. A drug that can produce a higher intrinsic activity at lower EC50 is a full agonist. The increasing concentration of EC50 to produce a full agonist activity or full intrinsic activity will be a substandard agonist. So these two graphs you must know by heart. I'm not going into this much. This is not the topic on antagonism or agonism. We come to the core topic of G protein coupled receptor. So there can be a short note on G protein coupled receptor as well, 4 to 5 marks. It can be up to 4 to 5 marks. So what are the few important salient points you have to mention? It is a 7 helical region. Okay, you have 1, 2, 3, 4, 5, 6, 7. 7 helices. Okay, it's a 7 helical region, transmembrane protein. It spans your membrane from outer to inner, transmembrane protein. It's a 7 helical regions, transmembrane protein. All these are keyword. Okay, I have just put the keyword. You mention like this is enough. In SAQ, you don't have to write in sentences. Keywords are enough, but you must mention the correct keywords. These are the right keywords. It's a 7 helical region protein, which is a transmembrane protein. It is a heterotrimeric protein. It means it doesn't contain all the same protein. It is trimeric means three different protein. Alpha, beta, and gamma. They have a alpha subunit, they have a beta subunit, they have a gamma subunit. It contains 3 subunit, which is heterotrimeric protein. Okay, what is the most important reaction that occurs in G protein coupled receptor is GDP being phosphorylated into GTP. Okay, GDP is being phosphorylated into GTP. Diphosphate become phosphorylated into GTP. Okay, triphosphate. And it will undergoes this transmit stimulus and causes signal amplification. There is G protein coupled receptors causes signal amplification and cascade of reaction via certain second messenger. This second messenger will propagate these signals and carry out the cellular effects. So this is G protein coupled receptors. Okay. When you have an agonist bind to a G protein coupled receptors, they undergoes a conformational change within the alpha, beta, and gamma subunit. Then GDP will be phosphorylated to GTP. We'll come into this in sequence. There are 3 types of it. There are 3 types of G protein coupled receptors: GS, GI, and GQ type. GS type, GI type, and GQ type. Okay, they have 3 different subunits. All of them have 3 different subunits. Okay, alpha, beta, gamma, but they differ in a different reaction where they either stimulate or inhibit a certain enzyme or they work through another enzyme, GQ. These 2 works to one enzyme. This is different enzyme. We come to it now. So as overall, before we go into the various types, how they differ, the overall what happens is first ligand bind to the receptor, number 1. Okay, a ligand, whatever drugs or natural chemical transmitter, whatever, they bind to the receptor. The moment they bind to a receptor, this G protein coupled receptor is combined with your 3 subunit as I mentioned, alpha, beta, gamma, where alpha subunit, where is your GDP is combined. Okay, your GDP is combined. So this is alpha GDP beta gamma complex, we call it. Alpha GDP beta gamma complex. The GDP is only attached to the alpha subunit, but beta gamma subunit is all three are in same. So when ligand binds here, it phosphorylate. There is phosphorylation of GDP to GTP. Okay, once GDP becomes GTP, the alpha GTP subunit dissociate from beta gamma dimer. Initially, it's the alpha beta gamma trimeric protein. After the GDP become GTP, the alpha GTP dissociates from beta gamma dimer. And this alpha GTP variance is where your GS, GI or GQ comes in. The variance of alpha GTP could be GS, GI or GQ, where they start cascade of reactions. First, ligand binding. Conformational change in alpha GDP beta gamma trimer into alpha GTP and beta gamma dimer because of GDP conversion to GTP. And then based on the variance of alpha GTP, either GS, GI or GQ, cascade of reactions occur. The cascade of reaction can be different, either involves an ion channel or it involves a cellular reaction involving a second messenger. So, as I mentioned, we have GS, GI and GQ. We go one by one. First, we talk about GS. GS and GI both involve enzyme called adenylyl cyclase, AC. Okay, this 7-elysis transmembrane protein, G protein couple receptor, have a alpha beta gamma subunit attached together with it, where a GDP is attached to a alpha subunit. Okay, once there is ligand bind to it, there will be a conformational changes from GDP to GTP. Once it's already converted to GTP, your alpha GTP subunit dissociate from beta gamma dimer. And if the alpha GTP is a variant of GS, S stands for stimulation, this will stimulate adenylyl cyclase. If the variant is the GS subtype, the GS subtype will stimulate adenylyl cyclase. And this adenylyl cyclase will produce cyclic AMP from ATP. There will be a conversion of ATP to cyclic AMP if it's a GS subtype. However, if it's a GI subtype, I stand for inhibition, will inhibit your adenylyl cyclase, where the conversion of ATP to cyclic AMP, cyclic adenosine monophosphate. Okay, in exam, here I'm using the word GTP, GDP for tutorial purpose, but you must mention at least once in your SAQ the full form of it and put in a bracket the short form before use it in a subsequent sentences. So CAMP is cyclic adenosine monophosphate. So GI will inhibit this adenylyl cyclase, thus preventing conversion of ATP to cyclic AMP. I mentioned the word second messenger. So the second messenger here is the cyclic AMP. Based on the variance of the alpha GTP, if it GS, it increases the concentration of cyclic AMP second messenger. If it GI, it inhibits the adenylyl cyclase, thus reduces the concentration of cyclic AMP. If it GS type, it increases the cyclic AMP. Cyclic AMP is the second messenger system. What does it do? It increases the calcium release. In turn, it will activate another enzyme, protein kinase A. And protein kinase A will involve in protein synthesis, gene activation, and change ionic permeability. These are all three cascade of reaction upon activation of protein kinase A. Okay, understand this. Adenylyl cyclase A will stimulate protein kinase A. The reason why I'm mentioning this, I'll come to it. Remember, adenylyl cyclase, protein kinase A to A. If it's GI, it just inhibits the adenylyl cyclase, so thus all these things does not occur. There is deduces cyclic AMP, so no second messenger, all these will not occur. That's it. So now we go to GQ, where a different enzyme is involved, not adenylyl cyclase. GQ, the same after the ligand binding, your alpha GTP dissociates from your beta gamma after conversion of GDP to GTP. if the alpha GTP subunit is a GQ variant. If it's a GQ variant will stimulate phospholipase C, PLC. Okay, phospholipase C is a lipase lipid enzyme. Okay, phospholipase C will break down membrane lipid. In our membrane, cell membrane, there is lipid. It will break down the membrane lipid with phosphoinositol diphosphate, PIP2 into IP3 and DAG. Okay, inositol triphosphate and diacylglycerol. Again, I'm using short forms here. You all have to know the full forms. At least once you have to mention it in your notes. So phosphoinositol diphosphate become inositol triphosphate and diacylglycerol. Okay, where IP3 as a action of calcium release in ER, endoplasmic reticulum. ER stands for endoplasmic reticulum, where diacylglycerol in turn stimulate protein kinase C. So this is the reason I mentioned adenylyl cyclase, protein kinase A, whereas your phospholipase C will in turn, by cascade of reaction, will stimulate protein kinase C. The second messenger here is cyclic AMP. Again, adenyl cyclase, cyclic AMP, protein kinase A. Whereas here, the second messenger is IP3 and DAG. The phospholipase C break down PIP2 into inositol triphosphate and DAG. Inositol triphosphate have stimulation of calcium release in endoplasmic reticulum, whereas diacylglycerol will stimulate protein kinase C and subsequent cascade of reaction. So that's what happened. So you have to understand GS and GI affect adenylyl cyclase. GQ, totally a different enzyme, phospholipase C. The second messenger here is cyclic AMP. Second messenger here is IP3 and DAG. I hope this is clear. Is this clear before I move on? Do you all want to explain again? Anyone have any doubts? Okay, good. So this is just, again, recapturing it. We talk about GS. So GS stimulates adenylyl cyclase enzyme. Adenylyl cyclase enzyme will convert ATP, they have phosphate molecules, ATP into cyclic AMP. Transform ATP into cyclic adenosine monophosphate. And the cyclic adenosine monophosphate will bind to protein kinase A. This is even more cellular because your protein kinase A have two subunits, regulatory and catalytic subunit. If you want to know, you can go and read about it, but not that important. This is even going deeper. So that stimulation of protein kinase A will cause all this, either protein synthesis changes, ionic channel changes, and everything trigger cellular response. Okay, GPCR involve adenosine cyclase enzyme, which is a GS variant. If it's a GI variant, it's simple. It combined to the thing, it inhibits the adenylyl cyclase. So there's no cyclic AMP, no, helps to inactivate the cell. Okay, it can be a feedback mechanism also. So GI. GQ, enzyme phospholipase C activation. So phospholipase C, phosphatidyl inositol 4,5 biphosphate, PIP2, will be breakdown into diacylglycerol and inositol triphosphate, DAG and IP3. DAG in turn will stimulate protein kinase C, where it will affect your protein synthesis and etc. Where your inositol triphosphate will have effect on endoplasmic reticulum, changes electrical charge of cell, can lead to depolarization. Okay, so understand the enzyme that is involved in the variant, different variants of your G protein coupled receptor. As an example, I can give you here the most common example or most commonly asked that you must know by heart is your inotropes. Your inotropes involve all these three types of receptors. So let's say you take of your adrenaline and noradrenaline. Okay, your adrenaline and noradrenaline can have your alpha-1 effect. Noradrenaline also has alpha-2 effect. Also have your beta effect. Okay, it can be any effect of it. Okay, so we don't think of adrenaline or anything. Let's say if it's effect and alpha-1. Okay, if it is alpha-1, what happens is it causes receptor stimulation. Alpha-1 is GQ, alpha-2 is GI, beta is GS. Okay, your inotrope acts via alpha-1 receptor, alpha-2 receptor, or beta receptors. So beta receptors are GS. let's say your adrenaline effect on your heart, okay, your chronotropy, your inotropy, all that. So it stimulates your adrenaline cyclase, cyclic AMP increase, causes heart muscle contraction, smooth muscle relaxation, and glycogenolysis. Whereas if it's alpha 2 receptor, it's GI variant. Okay, alpha 2 receptor is GI variant, so it inhibits, so no cyclic AMP, smooth muscle relaxation. If it's alpha 1 is GQ. GQ has almost similar function as GS, but it works via different enzyme. So again, it increases calcium enzyme. IP3 and DAG. IP3 causes increase in calcium release, thus causing smooth muscle contraction. So this is how your inotropes in different inotropes works via different receptor. So if you know which inotrope work via which receptor, GQ, GI or GS, you will no need to add by heart, remember, because you know if it's GQ, it will be a stimulation via IP3, DAG, what happens. If it's GI or GS, what happens and everything. So this is how I remember for all the inotropes we have mostly, because all our inotropes either works via alpha, beta or dopamine receptors like D receptors. I remember as EC lah, QI, SSSS, high. Okay, so if you have your alpha 1 receptors is GQ. You have your alpha 1 and alpha 2, your beta receptors beta 1, 2, 3, your dopamine is D1 and D2. Okay, your alpha 1 receptors are in your vascular smooth muscle. So alpha 1 is Q. Q is stimulation of phospholipase C, thus in turn causes IP3, DAG and protein kinase A, so they causes vasoconstriction. Alpha 2 is GI, GI is inhibition. That's why widespread throughout your nervous system. Alpha 2 is your Presidex, very simple. So it's an inhibitory, it suppresses. So it causes sedation, analgesia, and all these things. Then we have beta 1 and beta 2. So beta 1, we talk about platelet, it's okay. We talk about heart mostly, which is inotropic and chronotropic, which is GS. So beta 1 is GS, is stimulatory. Beta 2 also stimulatory. Okay, beta 2 as well stimulatory. Then we have beta 3, which is adipose tissue. Okay, all these are stimulatory. Okay. You might wonder why in beta 1 and beta 2, both are stimulatory, but why does it cause contraction in beta 1, whereas in beta 2, it causes smooth muscle relaxation? This is because different way where cardiac muscle and your smooth muscle contraction works. It's all related to myosin light chain kinase effect activity and everything. It's very detailed and everything. If you have watched my airway pharmacology slides or tutorial that I shared earlier, I would have went in detail about that. Okay, it all depends on how does the myosin light chain kinase affects your skeletal muscle versus cardiac muscle versus smooth muscle contraction. The sequence of excitation contraction couplings is differs. So that's why in bronchial or vascular smooth muscle, it causes relaxation. The cyclic AMP causes relaxation here, where in cardiac, it causes contraction. So, but don't worry about it. Just remember as this. Then your dopamine is S, as in your dopamine when you give your drugs peripherally, vasodilatation. Within central nervous system is GI. D2 is GI. That is why your dopamine we use for your basal ganglia patient with Parkinsonism. You get levodopa because they have very rigid and everything. You want to inhibit that and make them relax. Okay, so that is your D2. So this is key C. This is how I remember. So beta 2, this is why I said there's a difference where beta 1 causes cardiac contraction. You might wonder why beta 2 causes relaxation, because of the difference in this myosin light chain kinase phosphorylation. Okay, it's the initial sequence is all the same, GS stimulation. When you get beta 2, let's say a salbutamol for a patient with asthma, it will stimulate your adrenal cyclase. It causes cyclic AMP. Cyclic AMP activates your protein kinase. Your protein kinase inhibits the myosin light chain kinase phosphorylation, reduce intracellular calcium. That's why bronchial smooth muscle relaxation. This part, this myosin light chain kinase phosphorylation, it's where the difference occur between cardiac muscle and smooth muscle. I'm not going into detail about it. please watch my airway respiratory pharmac tutorial. I've talked about it in few slides there. Okay. Then another example, which is your anti-muscarinic. Just now we talked about anticholinergic. Your cholinergic receptors can be muscarinic or nicotinic. Nicotinic at the muscle end plate. Okay. Nicotinic, whereas your muscarinic is at the heart, it at your exocrine glands and everything. Okay. Your muscarinic receptors, anti-muscarinic receptors are also G protein coupled receptor, which is your GQ. They affect at your GQ, where they are anticholinergic, right? Anticholinergic. This is your, let's say you're talking about ipratropium or you're talking about atropine. So all these, what they do is they are anti-muscarinic. So acetylcholine antagonists at muscarinic receptors. So they block the GQ receptor. No phospholipase A activation, no breakdown of PIP2. So IP3 cannot stimulate calcium release in endoplasmic reticulum. And DAG cannot stimulate plasma. That's why when you give atropine, there is no smooth muscle contraction. You want to use it as an anti-secretory. Okay. And then you want to use as your, let's say use ipratropium as your bronchodilator, your combivent, everything, because there is no calcium release, there is no stimulation of protein kinase, so the smooth muscle relaxation occurs and there is no exocrine gland secretion. That's why it causes bronchodilation and reduces mucus secretion. So this is another reason why I put it is you have your muscarinic receptors, you got 5 types where you have M1, M3, M5. All the odd numbers are GQ receptors, your even numbers are GI receptors. Okay, your muscarinic receptors got 5 subtypes, the M1, M2 and M3. You can see the most important one where M1 is all your glands, M2 is your heart, M3 is your smooth muscle and exocrine glands. M2 and M4 is inhibitory. They are mostly in your central nervous system. Okay, mostly into a central nervous system as well. So this is how they act. These odd numbers are GQ. The even numbers are GI. This can come out as in MCQ. That's why I leave it here. Okay, these are simple way of remembering. All these as well I've talked about in recipe pharmacology tutorial. Okay, please watch that. So we come to a summary of cell surface receptors. Sorry, yeah. Okay, this should be, we'll come to these 2 slides later. I mistakenly put it there. Okay, so next type of linked receptor is ligand-gated ion channels. So these are receptors which is attached to a ligand-gated ion channel. There's ion channel attached to this receptor. So what happened? A ligand binds to this receptor. Once this receptor receives this ligand, it activates the channel, that ion channel that is attached to it. It gets activated as in it allows the ions to cross through. It can be any ions. It can be chloride, it can be sodium, it can be anything. So they are divided into 3 main things. It can be a pentameric, ionotropic glutamate or ionotropic purinergic. No need to worry about this classification much, but you have to know a few examples, as in your nicotinic ACH receptors. So nicotinic ACH receptors are ligand-gated ion channel receptors, whereas your muscarinic acetylcholine receptors are G protein coupled receptors. Okay, they are both are receptor linked, receptor based, but one is G protein, one is ligand gated. So this, when you have your acetylcholine binding to the acetylcholine receptor, it allows passage of sodium that causes depolarization and action potential reach, thus the muscle contraction occurs. And your GABA receptors got GABA A and GABA B receptors. Your GABA A receptors are ligand gated ion channel receptors, where your GABA B receptors are G protein coupled receptors. And you have your inotropic glutamate, your ketamine, xenon, everything. These allows ion channels as in magnesium, magnesium, sodium and everything. And you have your inotropic purinergic, which is involved in pain pathway. Okay. I'm not going much about all these ligand-gated ion channels and everything. You can read about it. Then we talk about enzyme link receptors. Enzyme link receptors, most common example we use is tyrosine kinase. Okay, these are receptors where there is an enzyme attached to the receptor. Okay, in this gem, this is the receptor. This is the tyrosine kinase enzyme. Okay. So what happens is when a ligand bind to the tyrosine kinase, when there is a ligand bind to the receptor, there is a tyrosine kinase will undergoes conformational change where they come nearby. You can see it comes conformational change where it comes to nearby. It will form a dimer formation. Then the tyrosine kinase get activated. In this form, the tyrosine kinase is not activated yet. Whereas once there is conformational change in the receptor bringing together this tyrosine kinase enzyme, dimer formation causes activation of tyrosine kinase enzyme, where ATP will be hydrolyzed into ATB, ATP to ADB, adenosine triphosphate to diphosphate, phosphorylation of enzyme, intracellular protein attachment, cascade of reaction, cellular response. So these enzyme link receptors mean upon binding of ligand to a receptor, the enzyme that attached to the receptor will undergo conformational change and undergoes activation, thus cascade of reaction occurs. You can read about it in detail on your own. Next, we go to intracellular receptor. It can be a cytosol receptor or nuclear receptor. Here we talk about nuclear receptor, which is most commonly a steroid. So a ligand has to pass through the cell, whereas in all the other three, they can attach to the receptor at the cell surface itself. But here, the ligand have to pass through the cells. So whatever the ligand or the drug, the substrate must be lipophilic. They have to able to penetrate through the lipid bilayer membrane. Okay, so they have to be lipophilic. So they have to cross the membrane, go to the cytosol, either a cytosol. If it's a cytosol receptor, they bind to a cytosol receptor in terms like thyroid hormone, or they have to go to the nuclear receptor like in steroids, where once they have bound to the receptor, they will form a complex with the receptor within the cytosol or nucleus. This complex will move into the nucleus where it binds to DNA, and ultimately these receptors involve in altering the transcription of your protein synthesis, either RNA or DNA. Mostly is RNA synthesis la, protein synthesis. Okay, direct effect into the protein synthesis, final outcome. So now we go talk about briefly on non-receptor based, which is this part. So what are the non-receptor based are? We have enzyme. Most of them are enzyme based. All of them, even DNA, here will be some enzyme, DNA gyrase, microtubule, mitotic phase enzyme, and all these things will come into it. So what are enzymes? Enzymes are biological catalysts. They catalyze a reaction. Okay, they are the mediator of a reaction from one end to another end. In practice, most of the drugs that we use are inhibitors of enzyme. We are affecting the enzyme as in we are stopping its action. So the action can be twofold. By inhibiting an enzyme, so let's say this enzyme metabolize the chemical substrate, it actually break down the substrate. So thus the effect of the substrate reduce in your body. Normally, let's say we talk about acetylcholinesterase enzyme. So acetylcholinesterase enzyme break down your acetylcholine into choline and acetic acid. Okay, so that is acetylcholinesterase enzyme punya action. So when there is enzyme inhibition, what happens is this metabolism is stops. This acetylcholine metabolism by the acetylcholinesterase enzyme is stopped. Thus, the concentration is raised. The acetylcholine concentration become higher because it's not being broke down. Though more effect, more contraction can occur. That is when we give anticholinesterases. Let's say you give neostigmine or anything. That is one way of enzyme inhibition. Another way of enzyme inhibition is it can happen. These is enzymes. What they do is these enzymes actually produce the substrate. They combine two things to produce another substrate. Like we talk about your protein kinase A and protein kinase C and everything. Okay, they produce a substrate. So when we inhibit these enzymes, this substrate that being produced is not more being produced. That's their concentration comes down. Thus their effect also comes down, like NSAIDs. So when we talk about NSAIDs, in your body, your prostaglandins being produced from your arachidonic acid. Thus, these various prostaglandin bring about various effects. Okay, like your platelet aggregation, causes pain, mediation, everything. Via enzyme cyclooxygenase, your arachidonic acid is being break down into prostaglandin by enzyme cyclooxygenase, whereas these NSAIDs are inhibiting this enzyme. Thus, they are not letting this arachidonic acid producing prostaglandin. Thus, their effect comes down. Thus, their mediation of the effect also comes down, which is desirable for us because we want to stop the pain mediation by the prostaglandin, where they also can give undesirable effect because this prostaglandin involved in platelet aggregation. When you have aspirin, it go and stop the platelet aggregation and causes bleeding. That's why it can be a desirable effect. It can be undesirable effect as well. So when we talk about enzyme inhibition, it can be competitive and non-competitive. Again, we use the same example, anticholinesterase versus NSAID. In an inhibition where competitive, you see this is your nicotinic receptor. Okay, your nicotinic receptor is a ligand-gated ion channel receptor. Your acetylcholine is the ligand here. Receptor is nicotinic. The acetylcholine will bind to the acetylcholine receptor, which is a nicotinic receptor, and it will open and allow the sodium passage and causes depolarization, propagation of the action potential, thus muscle contraction occurs. Acetylcholinesterase enzyme work is to break down the acetylcholine. Acetylcholine will bind to acetylcholinesterase enzyme, will broken down to choline and acetate. When you give neostigmine stops this, inhibit this acetylcholinesterase enzyme, thus inhibit the breakdown, increasing the acetylcholine concentration. So how they are competing when we give drugs is, when you give neuromuscular blocking agent, you have acetylcholine. So your neuromuscular blocking agent are competing with your acetylcholine to this space. It's a competitive antagonism going on here. So in competitive antagonism, whichever substrate have a higher concentration, they win. So how to make sure this acetylcholine concentration goes up? By giving something to inhibit the enzyme that break down the acetylcholine. So you give neostigmine, which is an acetylcholinesterase inhibitor or anticholinesterase, we call it. So it inhibits this enzyme, thus stopping the breakdown of acetylcholine. So acetylcholine concentration goes up, competing with this NMDA. Thus, you can get your muscle relaxant reversal again. You're reversing the muscle relaxation. In a non-competitive inhibition, as say in NSAID, they are not competing with something else. When you give this drug NSAID, they directly go and inhibit this COX-2 enzyme. Okay, when they inhibit this COX-2 enzyme, this metabolism, this pathway where arachidonic acid producing prostaglandin is not being going on. This whole thing stops here. Thus, arachidonic acid does not take the cyclooxygenase pathway. It will go lipooxygenase pathway. Read about the NSAID mechanism of action. Arachidonic acid actually goes to lipooxygenase pathway or cyclooxygenase pathway. Your NSAID, whether it's selective or non-selective, they will affect COX enzyme. Thus, these things are not being produced. It can produce a desirable effect like in inflammation and pain. It's good, but hemostasis all not good. It is an undesirable effect. So this is non-competitive. They are not competing with another thing. Whereas here we are competing. There is competition with the other ligands. Here there is no competition. Okay, that is the enzyme inhibition pathway. Next, just briefly on all this, direct effect on DNA, which is your quinolones. As I mentioned here, these non-receptors, even though they classify enzyme as separate, but almost other two also involve enzyme, whereas direct effect on DNA indirectly via enzyme inhibition. A classical example will be your fluoroquinolones, antibacterial, where they affect the DNA gyrase enzyme and interrupt your DNA synthesis. Thus, it's a bactericidal and arrest the multiplication. It acts as a kills the microorganism. I'm not talking much on all this, just for completion's sake. Microtubules, as in this is anti-cancer medication, your vincristine, everything. They actually interrupt the mitotic phase lah. So they inhibit the microtubules formation, alters DNA RNA synthesis. Don't have to sweat about it. Nothing important. Next, we talk about carrier transporter. Also indirectly an enzyme as well, the ATPase enzyme. Whereas a classical example, your proton pump inhibitor. Okay, multiple stimulus will stimulate your hydrogen potassium ATPase enzyme to produce more hydrochloric acid, thus increases gastric acid production. When you give your proton pump inhibitor like your omeprazole, it directly inhibit this carrier transporter enzyme. Okay, thus no secretion of gastric acid, reduces your gastric acidity. So that's your carrier transporter mechanism of drug action lah. Okay. Finally, voltage gated ion channel. As differs from your ligand gated, as I mentioned, ligand gated ion channels are ion channel that's attached to a receptor. And the binding of the ligand is not to the ion channel, it's to the receptor. They bind to the receptor, the ligand bind to the receptor, then only activation of channels happen. Whereas in voltage gated ion channel, this is non-receptor based, where your ligand binds directly to the ion channel and causes conformational change. A classical example, which is lignocaine. Why did I put this flowchart here? You might get a question on lignocaine, and your opening question could be a explain mechanism of action of LA, local anesthetic, in your Viva as well. These 4 to 5 sentences will give you a full marks. You don't have to mention a lot. If you can reproduce this is more than enough. This actually shows that you understand mechanism of your LA. If you want to get distinction, you talk about the activated state of your sodium channel, sodium gate, inactivated and everything. You can go more depth into it. That is the distinction part lah. Okay. So what happened? Lignocaine have to diffuses through the cell membrane in an unionized form. Okay, you can add on here unionized form diffuses through the cell membrane because it has to be lipophilic. Ionized form cannot cross through your lipophilic membrane, and it get ionized within the cytosol. Okay, unionized LA. When you give LA, it's actually ionized in your ampule. Once you inject into your local anesthetic, it get unionized in your skin, in your outer cell. Then it get passed through your cell membrane into your cell, where in cytosol it get ionized again, and the ionized part of your LA will bind to the voltage gated sodium channel, and it causes the blockage of entry of sodium channel into the cytoplasm, raises the threshold for excitation, thus no generation and conduction of action potential, local anesthesia occurs. Okay, so the binding of the ligand, it's into the ion channel directly as compared to ligand gated ion channel, where the ligand binds to the receptor. Okay, the most common example is in this would be your LA. Okay, this is the most common example. So before we go further to the summary, so this is to talk about receptor-based mechanism of action. You have G protein coupled receptor. I talked about it as they are metabotropic receptors. Okay, when they have second messenger system, they have signal amplification, they go through cascade of reaction, they involve ion change, they have enzymes within them. It's a long multiplication of process. Okay, it's not direct. They go through multiple cascade of reaction. Okay, that is metabotropic. A lot of metabolism goes. Tropic means stimulation, metabolism. It stimulate a lot of metabolism within before bring about the cellular effect. Okay, so it is seconds, not that fast compared to others lah. The classical example with muscarinic ACH receptor, opioid receptor, and alpha and beta adrenergic receptors. Okay, these are classical example. Next, you have your channel link receptors, inotropic receptors, which is direct effect because when the ligand bind to the receptor, it causes ion channel change, ligand gated ion channel. Thus, it causes hypopolarization, depolarization, immediate cell effect, millisecond, very fast. So this is your nicotinic receptor, NMDA receptor, and GABA A receptor. G protein coupled receptor will GABA B. Okay. Then you have your enzyme link receptors. Enzyme link receptors, as in your tyrosine kinase. These are slow receptors because the ligand have to bind to the receptor, then causes conformational change in the enzyme. Enzyme have to go through a cascade of reaction and everything. This is usually slow effect. Okay, this is kinase linked, usually tyrosine kinase, and so most common example will be a tyrosine kinase enzyme lah. Okay, epidermal growth factor, cytosine receptors and everything. Then you have your nuclear receptors. Nuclear receptors are actually these two are cell surface receptors. This is your intracellular receptors. This is also a slow effect. Most common example will be steroid receptors. Okay, you can see most of them affect the cell protein synthesis lah. Somehow protein synthesis or muscle contraction or depolarization action potential and so. So if all these are agonists, you can see in case of ion channel, bind to the receptor, acetylcholine receptor, activation of conduction, agonist, G protein, generation of second messenger. This is a tyrosine kinase, activation of cell signaling, and this is a transport of nucleus, transcription, translation. Just a repetition. Okay. So next we go to non-receptor mechanism. We have already talked about all these things. So summary. Mechanism of action again divided into physical and biological. Physical is direct, straightforward. It does not involve much of a metabolism. The drugs go and elicit based on the physicochemical properties. They directly elicit their actions. Whereas biological interaction involves receptor or non-receptors. Most importantly, the cell surface receptors are G protein, ion channels, and linked to enzyme. So G protein, most mentioned about your alpha and beta adrenergic receptors, your opioid receptors, your anticholinergic muscarinic receptors, histamine receptors, and everything. Ion channel, ligand-gated ion channel receptors, nicotinic acetylcholine receptor, your 5-HT3 antagonist serotonin receptors, GABA A receptors, then your tyrosine kinase enzyme linked, your insulin, your transdermal growth factor. Your nuclear receptors or cellular receptors are glucocorticoid and thyroid hormone, on your NO. Guanylyl cyclase also can be involved here. Okay, guanylyl cyclase GC. In coupled to G protein is AC, adenylyl cyclase. Here will be GC, guanylyl cyclase. So, and then we have metabotropic and ionotropic as well. So what I want you all to do homework is similar to this. Please do it on your own. List all the core drugs that we use in our day-to-day practice, whether it's OT or ICU. List all the core drugs, as in group them into classification, and then identify their type of MOA. Okay, just write there, let's say opioid. Right there, G protein coupled receptor, in bracket is GI variants. Just leave it like that. Then you write about your induction agents. List all of them. Okay. List. In case of opioid, you can just write G protein coupled receptor. The mu receptor is a type protein coupled receptor. You see, alpha, beta, and dopamine receptors. When I talk about alpha, beta, and dopamine receptor, they all are a type of G protein coupled receptors. Mu receptors. Okay, opioid receptors are mu receptors. The mu receptors are G protein coupled receptors as well. They are for that drug, it's a mu receptor. But what is the mu receptor? It's a type of G protein coupled receptor. The name is mu receptor. The brand is mu receptor. Well, what is the type of it? What model it belongs to? It belongs to a G protein coupled receptor. So in terms of induction agent, you mentioned about propofol. Do they work by GABA A or GABA B? If it's GABA A is what? GABA B is what? So GABA A would be your ligand-gated ion channel receptor, whereas your GABA B would be your metabotropic receptor. I want you all to mention like that. Then you talk about your muscle relaxant. Muscle relaxant comes under which? It's direct competitive antagonism. Okay, they goes into a different receptor, your nicotinic receptors. So not into a muscarinic receptors. So you have to mention all that. So most common are all these things. Your antihistamine receptor H1, H2, H3 also have different receptor mechanism. Your adenosine receptors. Adenosine receptor can be A1, A2, A3 and everything. So 5-HT3 receptors. 5-HT3 got various subtypes. So all this is your homework. I will share the listings in 1 or 2 days. In 1 week or so in the group. Before that, you all try to list it out on your own. So once you have listed out, you don't have to memorize it after that, because as I mentioned, 70 to 80% of them mostly are G protein coupled receptors lah, as I know. Okay. Other than that, certain drugs, of course, uses different mention. Especially your insulin, a few of it are different lah. Okay, your glucocorticoids and everything. But other than that, most of it comes into these two groups. Okay, most of it comes into these two groups. So please read again on G protein coupled receptor. There are few good animation in YouTube as well. You all can watch. Okay, that's all for today. Any